Hi, I'm Katie Schubert, President and CEO of the Society for Women's Health Research. I'm joined today by Dr. Jasmine Johnson, a third-year maternal-fetal medicine fellow and clinical instructor at the University of North Carolina Department of Obstetrics and Gynecology. We're so thrilled to have you here, Dr. Johnson. Thanks for joining us. We're focusing on maternal and infant health and health disparities in particular, knowing the rising rates of maternal mortality in the United States, as well as some sort of health disparities that have come to light in terms of the higher death rates for African-American women as compared to white women. I was hoping you could tell us a little bit about yourself, how you became interested in maternal and infant health, and sort of what your research focus is.
Yeah, well, thank you so much for having me. It's really great to be here and to have this opportunity to share my life with you guys. So, like you said, I'm a maternal fetal medicine fellow. So, what that means is I have finished medical school and residency in obstetrics and gynecology, which is a 4-year residency, and then I'm getting further subspecialty training in high risk pregnancy. So, ultimately, I'll just be taking care of birthing people who have complications either related to the patient or the other patient that I take care of, the fetus. And so as far as how I got into medicine, I'm actually the daughter of a physician. And so that was my earliest introduction to the field, spending time with my dad when he went to go round and sitting in the doctor's lounge. But when I went to undergrad at the University of Michigan, that was my first exposure to public health and how not only physicians are able to impact health within the confines of the hospital and clinics, but also able to do research where you can impact a larger group of patients and maybe even impact policy. And so I knew when I went to medical school that I wanted to do something that was kind of public health and patient oriented. And so it really, after doing all my rotations that I enjoyed, led me to OBGYN, where I felt like not only was I able to be a part of the life cycle of a patient and see them through and through really challenging times, but also do research that could be impactful beyond my state, within my whole country, and throughout fellowship have had wonderful mentorship to kind of continue to build on my goals.
No, that's wonderful. I think thank you for all that you do, especially now during a global health pandemic. And I was hoping you could talk a little bit. I know a little bit about your research in terms of preterm birth and health disparities, but if you could talk a little bit about what you've discovered related to health disparities in preterm birth, that'd be great.
Absolutely. So my research focus is health disparities, but particularly as it relates to Black maternal health. And so throughout residency and fellowship, I've done a number of projects where we looked at health outcomes such as preterm birth, which we know disproportionately affects populations of color, particularly Black women that have a preterm birth rate that can be up to 3 times that of white women, and also maternal morbidity and mortality. And so in one of our more recent studies, we looked at a national data set, so looking at birth certificate data, and we just looked at preterm birth outcomes in a population of women who had high socioeconomic status. So we define that by having greater than 16 years of education, not being on any government assistance, and having private insurance. And what we found is that even within a high socioeconomic status cohort of women, those preterm birth disparities that we see on a national level persist. And actually, as prematurity gets worse, so as babies are born at an earlier age, that disparity continues to grow. And so some of the more historical arguments for health disparities has been socioeconomic differences between women of different racial and ethnic groups. And that study was really important because it showed that that is not necessarily a protective factor for Black women, and that is consistent across a number of outcomes.
Hmm. What do you think? Why do you think that those disparities are happening? I mean, knowing sort of all that you've just laid out, do you have any sort of hypotheses about this?
Yeah, so there are a lot of hypotheses, and I think the best answer is that it's multifactorial. So when we think about health outcomes for the Black community, I think the biggest takeaway from any of these conversations is that race is not biologic. And so when we think about race as a risk factor, it's not me being a Black woman that puts me at a higher risk for preterm birth. It's my experience as a Black woman and how racism may play in as I navigate through society and impact our health. And so one one hypothesis related to that is something called weathering, where essentially we have found that the telomeres or the DNA strands of Black women age faster than white women. And some of that we think is related to chronic stress. And so if you think about stress, experiencing racism, but also thinking about stress related to how society has kind of impacted communities of color. So whether that's through redlining or food deserts or not having adequate housing or schooling just by virtue of your zip code and not necessarily anything inherent within you, and how that can trickle into health. Other things that we think about are overt racism. You know, you hear a lot about implicit bias. We definitely know that some disparities in outcomes are related to Black women not being listened to, or Black patients being treated differently than patients of other races. And so we definitely need to address that too. And, you know, when we think about this problem, instead of focusing on just the population that has a disparity, we need to think about how society as a whole impacts their experience. And so you think about the groundwater hypothesis instead of the fish. Instead of saying there's something wrong with this fish, we need to say what's wrong with the system that the fish is living in that's impacting their health and their outcomes.
And to that point, what can the medical and healthcare systems, and I think the societal factors as well, sort of what can we do as a society, as well as within the healthcare systems, to help address some of these disparities?
Well, I think the biggest thing is we've finally started talking about it. You know, this has been a really uncomfortable topic for a lot of people. And so for a while, it was just easy to hedge around conversations about racism in medicine, especially as it relates to even the history of obstetrics and gynecology. You know, that's something that we are finally talking about. But as a medical trainee, that is something I did not find out until later in my training through kind of my own research. And so we need to have these important and uncomfortable conversations to even acknowledge that there's a problem so that we can fix it. As far as healthcare systems as a whole, I think it's also important that we continue to track health outcomes by race and ethnicity, because even though we know that race is not biologic, it's not the risk factor, we know that there are differences and we can't fix them unless we track them. And so that allows for some more accountability on our part as a healthcare system when we think about different patients having different outcomes.
And then what about individual clinicians or healthcare providers? Is there something that they could be doing to directly address some of these disparities?
Well, the first thing we know when we think about severe maternal morbidity, or when a patient has a terrible outcome related to pregnancy, is that one of the biggest contributors in general across all racial and ethnic groups is delay in diagnosis, or just kind of provider not unreadiness, I'll say, where you're not equipped to handle emergencies. So I think that our first job as healthcare providers is to make sure that we have the tools and the knowledge we need to give equitable care. And then I think when it comes to populations that are more vulnerable, having conversations with those patients about the fact that you're acknowledging that there is a disparity, and that in acknowledging that you are doing things to mitigate it. So I think Black women are scared to have babies right now, and having a conversation with them in the before they get to the labor room, that you want to partner with them, that you acknowledge their risk just being a Black woman in America and what the statistics are showing, I think will put patients at ease and let them know that the healthcare system is not trying to do them harm. In fact, we're trying to improve outcomes. And I think that that is the first step in moving the needle.
Yeah, I mean, I think one of the things that was really great over the last few years is the sort of media spotlight on the maternal mortality crisis. I think also, however, what comes with that is this fear of becoming pregnant, going through the process of childbirth, and then wondering, you know, what could happen afterward, that I'm at higher risk for potentially. So I think that that makes a lot of sense. And one of the questions that we always like to ask here is, what do women need to know? And what can they do to advocate for themselves to achieve the best possible health outcomes?
That's a great question. Well, as a high risk pregnancy doctor, I think women need to know their body and their health. And so if you are not familiar with your health history, if you haven't seen a provider prior to pregnancy, even though most women are pretty healthy, it's good to kind of check in with your doctor before you even plan to get pregnant, to see if there are anything going on that could potentially make you a high risk pregnancy. And once you have discovered whether or not you're a high risk pregnancy, making sure that you get to a maternal fetal medicine physician like me, someone who is equipped to kind of lay out the plan for anything that deviates from kind of low risk care. The other thing, I think that we live in a country that spends so much money on healthcare, but we have so many patients that walk away from their interactions with providers and they don't feel listened to, they don't feel valued. And I think that that is something that is unacceptable, but also you don't have to stay with a provider that you feel is not listening to you and not valuing your participation in your care, because I think that that is a common theme among a lot of adverse outcomes, is that the patient spoke up and maybe someone wasn't listening, or their advocate spoke up. And so I always tell my patients that not only should they advocate for themselves, but they should not feel that they are burdening their provider by doing so, because it is their job to speak up, and it is our job to, of course, give our expertise, but make sure that our patients understand what we're recommending.
Yeah, that's great advice. And I think knowing that you're very active through your research as well as your membership in medical professional societies throughout your time, I'm wondering if from a policy perspective, you think there are any steps that the US government could take that might have an impact on maternal mortality rates, or even at the state level, or maybe models in other countries that might be helpful for us to look at.
Yeah, this is a great question. And the Society for Maternal Fetal Medicine and also ACOG, our kind of governing body for obstetricians and gynecologists, we all agree that Medicaid expansion is something that is a policy that in states that have expanded Medicaid, we have seen decreases in preterm birth rates and decreases in maternal mortality rates. And so that is something that we are really, in the states like mine, where we haven't seen Medicaid expansion, we want to make sure that we are talking to our legislators about how that can be a really, really low-hanging fruit when it comes to moving the needle on maternal mortality and adverse maternal outcomes. With the passage of the Preventing Maternal Deaths Act, we are able to get more funding for maternal mortality review committees, but I think that we need to take it a step further. And thankfully, Congresswoman Adams, who comes from North Carolina, is one of the founders of the Momnibus, which is this awesome plethora of bills that help to continue to push for equity in maternal health care, safety, accountability, and kind of all of the things that we talk about being important when it comes to reducing healthcare disparities.
Great. Yeah, I think there's a lot of conversation surrounding policies, and it's great that this is being discussed and taken seriously in the more recent history. And I think to that point, our current VP-elect, Kamala Harris, has a strong history of promoting policies that address issues of implicit bias, both in the healthcare system and outside of it, but also she's looking at sort of how can we talk about this issue and impact policies that would improve birth equity. I'm wondering if you have any thoughts or hopes for the next administration and maybe what they might be able to achieve in these areas.
So many hopes. I'm really excited to see the next administration transition. But I would say what my biggest hope is that there is more transparency in these outcomes across the country. I think that some hospital systems are doing a really great job of tracking outcomes and creating metrics that are measurable to show change. And then, not for any fault of their own, but because the funding isn't there or the resources aren't there, we just don't see that across the board. And so I would love to see some type of standardization when it comes to tracking maternal health outcomes. And then I think we need to start in the professional schools, the pre-professional schools, talking about implicit bias. Yes, it's important to do it now that we're practicing physicians or you've been out for a while, but it really starts in medical school and nursing school. There was a study in 2016 out of Virginia where basically they interviewed medical residents, they interviewed nursing students about false beliefs between Black and white patients, and they found that there were a lot of false beliefs that students held regarding Black Black perception of pain, saying that like Black patients have thicker skin or like didn't feel pain the same way, that would impact their assessment of a Black patient and how they treat them. And those are people who are now practicing as nurses and physicians. And so that's pretty scary. And I think that yes, we need to fix things that are happening currently in the hospital, but we need to go even further downstream where it comes to diversifying our medical field, where it comes to making sure that the future of medicine is not holding racist beliefs, and that we're creating a culture of equity from the beginning.
Thank you so much. I think that's so important and such a good message, to really start from the beginning and incorporate it back into all of the work that's happening so that everyone has the same access, coverage, ability to ask the right questions, and seek the care that they want and need. And hopefully, ultimately, that will lead to improving health equity in the country.